stem. There's different options. I think that fractures happen when surgeons have one stem, and they use the one stem for all their patients. People have different femurs, and you should choose different stems when you choose the cementless fixation. You want to choose what length you want, and it depends on the patient size, depends on the morphology of the femur, the shape and geometry of the stem you want to choose. Not every femur is the same, every stem is different. Where do you want the fixation? Proximally, fully porous, distal fixation. Do you want a stem that has modularity? Because you need to adjust or have ability to change your version. And you should also know what coding your stem has. And what do you have in the registries? What are the best performing stems? Not all stems are the same, even if they look the same. So you all know the different morphology of the femurs, the classic door A, door B, and door C. Just by looking at these pictures, it's impossible that the same stem is the best stem for each one of these morphologies of the femur. You want to know the Gruen zones. Where do you want the fixation? Where do you have good bone? Even though it's a primary total hip, not all patients have good bone. It can be patients that have rheumatoid, patients that are on dialysis, patients that have previous fractures or infections. Not all of the zones are good and able to have cementless fixation. So there's a nice review article in JBJS that shows different kinds of stems. And I think as a surgeon, you should have 2 or 3 stems that you're comfortable using, and you choose them. And as Thorsten said, I also cement my patients. I cement my fracture patients, and I cement my older patients. I'm not strict, as Thorsten at 75, but at 75, I start thinking about it. And I make the decisions, and I make sure my fellows and my residents know how to do a cemented stem. If not, I do a disservice in how I teach them as their teacher. You have to know the coding. There's different codings for the stems. Some have better fixation, some have not. Even stems that are marketed as proximal, they may be grid blasted. An example for that is the DePuy Summit, the Smith and Nephew Synergy. Those stems have almost fully on-growth on them all the way to the tip. So you have to know that. In short patients, it may cause distal fixation and proximal stress shielding. So knowing where the ingrowth is. So you have porous metal, you have sintered beads, fibered mesh. You should know the differences, and you should know what your stem has. I'm sure all of you know exactly how your car, how many cc's it has, how many cylinders, your TV, your computer. You should know your stems exactly. How many degrees they have, what coverage, how much of coverage. What about HA? HA is very popular. A lot of different companies have HA coatings on their stems. If you look at the outcomes in different studies, this is a good study, a randomized study that compared HA and non-HA coating with the same stem, looked at survival in 12 to 15 years. In 13 years, no difference in the survival between HA and non-HA. Both of them done extremely well with very low, if almost none, no revisions due to aseptic loosening. If you look at the Swedish registry, and you see another comparison of the same stem with HA and non-HA coating, the outcomes and 10-year survivals, the number of revisions are low. If you look at aseptic loosening, it's less than 0.5%, and the difference between HA and non-HA are minimal, if it all exists. So after you choose your coating and you choose your stem, how long do you want your stem? Do you want a very short stem? Do you want a medium stem? Do you want a longer stem? The advantage is going shorter, you have less proximal shielding, you have to resect less bone, you save more bone for later. If the patient is young and may have more surgery, so that's something to think about. And also think about thigh pain. Short patients with long stems may have thigh pain down the road, especially if they have tight fixation. And again, the design of the stems, you should go as long as you need, as short as you can. And the shortest stems are neck preserving. I personally do not use them and don't have experience with them, but there are a few that have outcomes out there, as well as the shorter mini stems. You should use them with caution. You should know how to use them. You should not use them the same way you use your regular stems. It's a different technique, biomechanically, they rely on a different area of the femur of the bone, and you should make sure you understand how this stem works and how to put it in. And when you look at other shorter stems, they are basically stems that were longer and were cut down a little bit, but they have the same proximal morphology as the longer stems, and they just don't have the stem. The challenge there is putting them not embarrassed and putting them in a correct orientation, because they're not long enough to engage the femur to give you orientation. But if you take examples from the anterior approach surgeons, it's not that the anterior approach is easier to do leg length and put in position, it's because they use fluoroscopy. So if you want to have better outcome, you can bring x-rays and fluoroscopy or navigation into your operating room if you feel that you can't get the perfect position of your implant. Let me show you cases and we can discuss different stem selection. So a young patient, 28-year-old, bilateral hip pain. You can see the x-rays on a 28-year-old. So I'm thinking about a stem that will be able to fill that canal. I personally like to fill canals when I have the more of a type 2, 3, and I use a more fit and filling stem. So I use a stem that's a dual taper, that it's a Riemann Roche system, and I can fill that canal and feel comfortable with my fixation. I also want a long-term fixation, so a stem that has a good track record. Another example of a young patient, 35-year-old female, long-standing joint pain, has sickle cell anemia. I'm sure you see a lot of it here. You can see now we're looking at the opposite of that. This is a type A femur. So a type A femur, I feel uncomfortable using an ML taper, a single wedge. I feel it's hard to open the distal part, and you have a mismatch between the distal and proximal part. So again, I want to use a stem that's a Riemann Roche. I can ream that canal, open it up to fit and not have a mismatch between proximal and distal. So the same thing, I'll use a fit and fill dual taper Riemann Roche stem, which will allow me to match the difference between the canal and the proximal part. Another example of a young patient that had a girdle stone in a young age. So you have a patient that has this x-rays, and your biggest challenge, there is no neck. Your area is, with aversion is problematic. Using a stem that has inability to adjust for version will be a challenge, because you may be stuck with most of the stem outside of the femur where it's supposed to get ingrowth. So I want to look at a stem that allows me freedom of version, that I can put it. That's also a good option to do cementing. Cementing always allows you to play around with the version, but in a young patient, in my hands, I prefer to use a non-cemented stem. And for this patient, you can see here on the x-rays, you don't really have a proximal femur. On the CT, I'm planning for a modular stem, and I use a modular stem that allows me freedom of version of the stem, that I can position it in the proper version, have good fixation proximally. This stem does not get a lot of distal fixation, has no on-growth surface on the stem, so I'll be preserving for bone for the future for this patient if I need to. Another young patient with girdle stone, very similar. A different option of a stem, instead of using a modular stem, you can use a Wagner type stem, which will allow you freedom of rotation. So the same kind of patient as before, same problem. I'll use a Wagner type stem, allows me freedom of version. I can put it wherever I want. I get a fixation more in the metaphyseal diaphysis region, not very proximal, and it gets good fixation and I get good orientation of my stem. So what about DDH patients? More challenging. Again, a young patient. This is the x-ray. So I don't know how to do this cemented. I have to use cementless for this case. So we need to do a subtrochanteric osteotomy. And again, my options would be either using a Wagner stem that I know my partner Will Long likes to use. I like to use a modular stem in these. So when I go to reconstruct this, I do a subtrochanteric osteotomy. I put a modular stem. I get proximal fixation, distal engagement, and sometimes you can add an anti-rotational plate connecting the two parts to avoid rotation between the parts that you don't feel you have good distal fixation. So let's go to a little bit more complex primary cases. Patient has deformity from a young age. He's in his 50s. He has two separate hips, and he comes to me and says both hips are a problem. So as usual, I go for the easy hip first, and then maybe he'll go to Will for the second hip. So I choose the left side first. I feel I can challenge this hip, which is a type 2. I think the version won't be too much of a challenge compared to the other side. And I go for more of a fit and fill stem for the left side. And as I do the mini posterior approach, if I think the case is complicated, I'll bring x-rays into the room and take an x-ray. Remember, when you take an x-ray during the case, you accept nothing but perfection. When you take the x-ray after the case, you accept everything but a failure. So if you're unsure, and for my fellows, I tell them the first few years of practice, take an x-ray in the operating room while the patient is still open in all your cases, until you don't have to change anything for a long time. So this was the first side, the patient was happy, he comes back for the other side. The other side is a challenge. We can make it into a complex case and do an osteotomy and correct the deformity and put a stem that will engage both sides, or maybe we can go with something shorter. I was young at the time, I wanted to try something more challenging, so I decided to use something shorter. I used also a navigation system, that's the metal part you see on the greater trope there to help guide me on leg length for the patient. And then I did a short one, and because I was not familiar with the stem, I put a cable just prophylactically to make myself sleep better at night. So what about old patients? We just talked about it with Thorsten. Patient had a hip fracture, or had a fracture a long time ago, comes with bad arthritis. At this point, it's not a trauma patient. Patient is 80-year-old. You can see the quality of the bone. In Thorsten's hands, it will get a cemented total hip. In my hands, it gets a cemented total hip as well. So that's a take-home point here. You have to choose for each patient what's correct for them and what you're doing well. If you have only one tool in your toolbox, you will have problems and fractures. If you have many tools and you give the right tool for the right patient, your outcomes will be better. Thank you.
Thank you.